from the screws, we are going beyond where we can use the O-arm. So it's well established that the O-arm and navigation helps us in putting on the screws safely and with less radiation, and larger and longer screws can be put with less revisions rates. So with the advent of the newer tools and technology, like the Jamshedi needles, the burrs, the cobs, the osteotomes, the extension of the indications of O-arm has extended into placement of interbody cages. It can be used in spinal tumor resections and with cystic lesions, percutaneous procedures like bone biopsy, vertebroplasty, and kyphoplasties. And also it can be used with minimal invasive lumbar decompression surgeries and complex procedures like osteotomy and deformity corrections. So with the navigated biopsy, it can give us a three-dimensional orientation, enabling us to reach the exact desired pathology and obtain the adequate tissue with decreased radiation and avoid injury to the major structures. Just an example of taking the biopsy from a cystic lesion at L5, lytic lesion at L5, with great accuracy. So just an case we had, a male 33 years with upper back pain since 1 month, with normal neurology and blood parameters. X-ray was normal looking. The MRI showed a lesion at D3 vertebral body and a D8, a small lesion. So we decided on to take a navigated, O-arm navigated biopsy from the left side, transpedicular biopsy. So with the biopsy, we could target the inferior aspect of the vertebral body where the lytic lesion was there very accurately. And with the navigated Jamshedi, we could reach there. The X-ray shows the confirmation of the picture, and we took that biopsy. In case of lumbar interbody cages, we can place the cages perpendicular to the intervertebral disc space, and as well as avoid the injury to the ALL, also avoid encroachment into the spinal canal and end plate, which is very common when we do it under fluoroscopy. So this is an example of a TLIF where the cage is being placed absolutely at the center of the interbody space and in the middle of the vertebral body with the X-ray picture on the right side. So looking at the literature, the interbody cages, it was shown that the placement of the cage in LLF, lateral lumbar interbody fusion, it's feasible, safe, and accurate, as well as may reduce the radiation to the surgeon and the team. 97% of the accuracy in cage placement and multi-level surgery cage placement was satisfactory. Now coming to the complex surgeries where we do spinal osteotomy and deformity correction, it again gives us a three-dimensional visualization of the extent of and trajectory of the osteotomy, which optimizes the accuracy of the bone cuts. Actually, it actualizes the preoperative plan of the osteotomy. We can see it where we are cutting it, either we're getting into the end plates, and how much of correction we can achieve. So it can especially useful in pedicle subtraction osteotomies, vertebral column resections, and hemivertebrectomies in congenital scoliosis and kyphoscoliosis, and as well as prevent us from iatrogenic neurovascular injury. So also a cage, when we try to put after a corpectomy, we can put a larger and appropriately sized cage with significantly lower rate of malposition. So coming to the management in spinal tumors, it is well documented that the navigation system can improve the surgical accuracy with screw placement and tumor localization and excision of the tumors. So it's also well documented that it can be safely and efficiently used with number of advantages, like it can guide the excision of the tumors, complete eradication of the lesions, as well as maintaining the osteotomy according to the preoperative plan, and maintaining the tumor margin integrity with less intraoperative complication and less recurrence rates. So these are certain examples in the literature where en-bloc resection of the sacral chordoma has been done, and with decreased likelihood, looking at the complex anatomy of the pelvis, there is high chances of having a neurovascular and injury to the normal tumor, normal anatomy. So there is a decreased likelihood of injury to the vital organs during the osteotomy or violation of the tumor capsules, and increase the likelihood that the appropriate surrounding tissue was resected for wider and marginal resection. So another clinical case where we use the navigation. It's a 71-year-old male with neck pain, sudden onset of weakness in both upper limb and lower limb with instability while walking. The MRI shows a pathological lesion at LC4 with significant cord compression. Both anterior and posterior elements were involved. So two-stage surgery was planned. After the first stage of the surgery, we took the O-arm navigation to see the adequate removal of the lesion, and it was followed by the posterior pedicle screw fixation in the cervical spine. That's the final post-op X-ray. It also has use in metastatic tumors where the navigated probes and curettes in conjunction with the intraoperative ultrasound can facilitate and verify goal achievement in separation surgeries. And when direct visualization is not possible, image guidance in the form of navigation and ultrasound becomes the most reliable means of visualizing the anterior epidural space. It can be also useful with ablative procedures like laser interstitial thermotherapy, radiofrequency ablation, where the navigated probes can be more accurately positioned for both the radiofrequency ablation and cryoablation. And also useful in brachytherapy, where the navigation with CT and MRI can be used to exactly target the lesion in difficult areas before the brachytherapy administration. More and more navigation is being used in revision spine surgeries, where actually it makes the surgeon's life easier for surgical exposure, where we can identify the laminectomy and the bony defects which has been previously made. And it also helps in identifying the disc space and the foramen easily, where it is obliterated by the scar tissue and prevents us from iatrogenic dural tear and nerve root injuries and cord injuries. It's also very commonly being used by the endoscopic surgeons or the minimally invasive surgeons, where the navigated burrs can help you do adequate decompression, as well as it can prevent us from having a iatrogenic instability and excessive removal of the facet joint. There's a new technique, that the transpedicular and transdiscal screw placement, which is technically demanding in nature, and it can be difficult in putting in under a fluoroscopy because of the angulation which it needs for 25-degree angulation to put into the superior vertebral body. So with the navigation, this has become more feasible, and it can be done in cases where the bones are very weak, like osteoporotic fractures, osteoporosis, or in patients with disc and ankylosing spondylitis. So having said all these things, so gradually our indication of O-arm navigation is increasing gradually.
Okay.
So with the, just 1 minute. So with the, and in future, I think with virtual reality and artificial intelligence and the amalgamation of the NIMS with the navigation, it's going to make it more safer in future. So I thank you. So at the end, I would like to invite all of you for the upcoming ISIC spine course, and from 22nd to 24th November. It will be a great course especially for the upcoming spine surgeons and the fellows. Thank you.